us a little bit about your background and the core thrust of your research.
Sure. I direct the Macular Research Group at the University of Sydney, the Save Sight Institute. That has three units. We have a clinical research unit, which really pioneered the use of steroids. We started using triamcinolone in Sydney in 1992, I think. So I think we conducted one of the first intravitreal therapy studies using triamcinolone to treat neovascular macular degeneration in 1998 when we started that. And we subsequently tested that for diabetic retinopathy. It wasn't very good for neovascular macular degeneration. The laboratory is now mostly interested in Mueller cells. This is an overlooked area of the macula and how Mueller cells contribute to retinal pathology. In particular, our favourite condition, macular telangiectasia type 2, or MACTEL. The MACTEL project is now a big project. We've established that Mueller cells seem to be playing a major role in that condition. Right. In terms of macular degeneration, probably our biggest contribution has been establishment of an observational registry to track the outcomes of treatment of macular disease, particularly neovascular macular degeneration, which we've been doing since these new drugs have been released in 2006. And I think this outcomes research is really going to transform medicine in many ways. The outcomes that we've tracked in Australia are actually pretty good. They're similar to sort of the Marina phase 3 clinical trial results, mainly because there's no restrictions on access to the drug in the States. The government is fully funding it, the patients don't have to pay for it, and the surgeons are reimbursed for doing the procedure. So everyone has got a good incentive to do a lot of injections, and we've established through our research that this is probably why we're getting the best outcomes. Now, in the UK, for example, and in Europe, when they started publishing their outcomes research, they found very poor results. So that's really the first lesson. They would have had no idea how poor their results were unless they'd actually done this outcomes research. But it turns out that the first study by the UK Electronic Medical Record Users Group, they only tracked about an average improvement in visual acuity of their patients of about 1 letter, and it declined under the baseline level by about 1.5 years. In our cohort, we found a 6-letter improvement after 6 months, and that didn't tank below baseline for 6 years. And the big difference was actually not a big difference, a small difference in the number of injections. They were using a PRN regimen. They were seeing patients more frequently, but treating them less frequently. So they were giving an average of 5 injections a year in the first year. We were using treat and extend, and we were giving 7 injections a year. Then after that, we're giving 5 a year indefinitely, whereas in the UK they were giving maybe 4 or 3 a year and tending to tail off, trying to stop the treatment. So they've realised by this comparison that they need to boost their capacity, and they're doing that now. I think it's going to make a big difference to the outcomes in Europe. And the same goes for Europe. The results in many European countries have historically been very poor, and I think they also realise that they probably will do better if they give a few more injections to their patients and they use a treat and extend regimen. And we like to think we've played a role in bringing people to this realisation, really by setting an international benchmark in what you can do if you treat adequately.
Have you seen any complications associated with giving more injections over a longer period of time?
Well, this is very interesting. So the big worry is that the anti-VEGF causes geographic atrophy, and obviously we're all aware that there is some data from the CAT study that the patients who received more injections tended to get more atrophy after 2 years. Then the 7-Up study reported very poor outcomes at 7 years. They found nearly a 10-letter mean visual acuity loss at 10 years, and they reported that over 90% of the patients had central macular atrophy. When we did our 7-year analysis, we had twice as many patients, we had 130 patients, and our results were much better. We had a mean of 2.5 letter loss. The mean visual acuity didn't, as I said before, didn't hit baseline until about 6 years. In them, I think it was 4.5 years in the 7-Up. But when we looked for the cause of vision loss, we did find atrophy, but only in 40% of eyes. And in other eyes, it was due to things like subretinal fibrosis, which may be caused by undertreatment. And the big difference again, between the two studies was that in 7-UP, after the first 4 years, which was the randomised clinical trials and the Horizon phase 4, they treated very infrequently, only 1 or 2 injections a year. Whereas in the Australian cohort, we were giving 5 injections a year all the way up to 7 years. So that's not really consistent with the injections causing atrophy. But there's still a story there. And we've also recently had a look at, because we grade atrophy as part of the things that we track, we've had a look at atrophy as a function of whether the lesions are active or not. So we followed around 1,500 eyes over up to 9 years. It was a cross-sectional analysis. We didn't follow each eye individually, but the cross-sectional analysis showed that the atrophy increased to about 42% after 5 years, which is a bit under the CAT estimate of 48%. But at 9 years, it was only 50%. So it appears to plateau at 5 years, but there's no other data apart from ours. But we're hoping that that will be confirmed by the studies, that some patients get it, and if they're going to get it, they'll get it within the first 5 years, and then you're less likely to get it. But the interesting finding from our study is we grade lesions as active or inactive. We don't discriminate between sub or intraretinal fluid, but we grade them as active and inactive. The most active lesions were 4 times less likely to get atrophy than the least active lesions. There's a very big difference. So it may not be so much the injections, it's just completely drying out the macula. And I think this is where the field is changing now, in that some people will accept the degree of subretinal fluid. It might be a good thing.
I think that's a very fascinating sub-analysis there. What are the therapeutic implications going forward in terms of either improvements or changes to VEGF therapies that can further modulate and improve upon some of these outcomes? In your mind?
We've heard, yes, well, we've heard a lot at this conference about the pipeline for neovascular AMD and the same drugs for diabetic retinopathy, diabetic macular edema. It's a rich pipeline. They've got about 20 drugs that are in various stages of development. I think some of these are very exciting. Brolucizumab looks very exciting. The combo molecule with the Ang2 with the VEGF inhibitor in the one molecule is very exciting. But I'm sort of, even though I do laboratory research, I'm of the view that as soon as you get past preclinical into clinical, it's all empirical, and you just have to see what the results are. Right. Now, we all thought that Eylea was much stronger and lasted longer than, aflibercept versus ranibizumab. Our studies don't really support a huge difference there, and we will set up to track brolucizumab as soon as it's released, and we will find out very quickly in the Australian population, because we will all be treating and extending as if it was just aflibercept or ranibizumab, and we'll see how far we get. So I think these observational studies will be critical in validating what the clinical trials appear to show, or at least what the sponsors of the studies claim that the studies show. The real world evidence really trumps anything when it comes down to the actual outcome and how you have to use the drug.
Right, right. When you look at preventive modalities and preventive strategies, what kind of preventive strategies have you been using in Australia in the at-risk population? Well,
I think we do generally use the AREDS formulation. Mm-hmm. The original AREDS formulation, I know the English are not at all keen on it. They hardly use it there, but I'm not sure how much it's used in the States. But in Australia, it does tend to be overused. Like you'll find 50-year-old people whose mother's got, a bit of AMD and they're taking it too. So you've got to talk them out of that. I don't like people being on long dose, major antioxidant doses because it's a heavy dose. Mm-hmm. But certainly, if it was me or my mother who had a neovascularization in one eye, I would be taking that regimen because I think there's reasonable evidence that it reduces the risk of neovascularization in the other eye. That's the main thing. There's the fish in the leafy greens and staying healthy and all that.
Right. So what about other cofactors? Smoking?
Smoking's a big one, of course, and interestingly, not this conference, but in New Retina, that people were talking about how can we make a further improvement? How can we, because the big story, of course, in ophthalmology is that the incidence of blindness has halved since anti-VEGF came on board. but can we get it down further? And one way to get it down further is by driving optimal treatment patterns through outcome registries, is what we've just talked about. The other way is to stop people smoking, because there's still a lot of smoking going on, and that causes a lot of disease. So I think smoking is a very important one.
Switching to future directions for your research, what's
Yes.
on the menu?
Actually, the laboratory, we will expand the registries we have a diabetic macular edema module now, and we're actually expanding that to all aspects of ophthalmology, but in retina it's going to be DME, AMD and retinal vein occlusion. And we hope to expand that to Europe. We're currently expanding that in Europe. We have quite an advanced pilot project in the Netherlands, established in Switzerland. We have small projects in the UK, France and Spain, so that'll be one thing. In terms of laboratory research, we're interested now in outer retinal metabolism and serine metabolism in the retina is not very well understood. It's very well understood in cancer. There's a lot of stuff that goes on in cancer that also is very relevant to the eye, because the retina has a cancer-like metabolism. I'm not sure if you're aware of this. It's a so-called Warburg effect, where it gets its energy from glucose through glycolysis, even when there's adequate oxygen. It's a Warburg effect, originally described for cancer, but the other place it operates is in the retina. And serine metabolism drives the production of glycine and antioxidants. So we're looking at ways to boost serine production in the retina. That's one aspect of what we do. We've looked at some stem cell applications. There's a lot you can do with, induced pluripotent stem cells. It's amazing. These retinal organoids that you can grow in culture, and they can sense light. It's quite extraordinary, but we've only come 10% of the way if you're talking about putting these things in eyes and they're going to start, receiving light and transmitting it to the brain. So even though the advances really, compared to 10 years ago or 15 years ago, really unimaginable, there's still such a long way to go with that stuff.
So you're actually doing some stem cell work in your lab?
No, the people who are doing that sort of moved on. We're focusing mostly on outer retinal. This is a long-term project, Muller cells and outer retinal metabolism. There's quite a lot of basic science there, but yes. It might help us. We can understand how Muller cells are, everyone understands the photoreceptors as being supported by the RPE, which they are, but there's also the Muller cells, which are not a lot less important than the RPE. The outer limiting membrane is formed by the Muller cell process, where they contact the cones, the apical processes, and there's a lot of interaction that goes on there that we don't understand. So nobody has really got a good idea of what Muller cells are doing in many retinal diseases. There's very likely they have a role in diabetic macular edema, diabetic retinopathy, and they probably have also a role in AMD, especially RAP lesions, but it's very poorly understood. So this is sort of blue sky research, trying to make a better understanding of biology to see if we can understand what the pathology that flows from it is.
Absolutely. Turning to the message for patients, what would you say the implications of your work are for patients, specifically with regard to the treatment extension and those regimens, and then generally with regard to the future directions of your research?
Yes, I think it's very important for patients to understand that this is a lifelong treatment, at least the way we have it now. Now, if they've been successful in stripping pericytes off blood vessels and make the blood vessels regress, it might be a different story. But at the moment, what we have is a treatment which will stabilise vessels but won't get rid of them. And our research suggests that over 90% of eyes, the lesion will eventually recur. So they've got to prepare themselves for a lifelong journey. It's not just 1 or 2 injections. If they don't accept that, they're unlikely to get a good outcome. I tell my patients that if they see me on the street, they should start running, because every time I see them, I'm going to give them an injection in the eye until one of us dies. You have to get that message through. And if you do get the message, some patients do extraordinarily well. 10 years, I have a patient who completely blind in one eye, well, not completely, but lost all the macula. from the same process, and this eye she's been 6/6 on 4 weekly injections. The lesion has never become inactive. It's been persistently active all the way through. Maybe that's telling us something. She's still seeing 20/20 or 6/6 vision after 10 years, over 100 injections now. So you can get remarkably good outcomes, but it really does take commitment. Does take the patient commitment.
Excellent. Professor, thank you so much for sharing all of this excellent insight.
It's a pleasure,
and we
David.
look forward to watching and learning from your research in the future.